Welcome to Webisode 15, Methadone, EKG Testing, and the QT Interval. I'm Lisa Wheeler. I'm a physician assistant with over 25 years of experience in several specialty areas, including orthopedic and emergency trauma medicine. For the last 6 years, I have been practicing in the areas of addiction medicine at an OTP, as well as OBOT and pain management in a private practice setting. Over the past 10 years, confusing and sometimes contradictory recommendations have been made regarding EKG screening of patients being prescribed methadone for opioid use disorder. As we know, methadone is one of many drugs that can cause prolongation of the QT interval. Because of this, we worry that patients with QT prolongation being treated with methadone could be at an increased risk of developing an arrhythmia called torsade du point, a potentially fatal disorder. In fact, since 2006, the FDA has placed a black box warning on methadone, cautioning of QT prolongation and the risk of torsades. This gave rise to many questions. Should we do screening EKGs on all patients starting methadone? Should we screen high-risk patients and only do EKGs on them? Is the OTP responsible for doing the EKG screening? If OTPs do EKGs, who pays for them? Who interprets them? Many providers at OTPs may not be comfortable interpreting EKGs. In 2013, the Cochrane Review Group investigated this issue. They recognized the risk of untreated opioid use disorder and the reduction in mortality in patients treated with methadone. They also acknowledged the logistical problems of doing frequent EKG screenings. The group did an extensive literature research trying to find data on which to base a recommendation. However, no studies could be found that both directly addressed the issue involved and met the group's standards for quality. Therefore, the Cochrane Review Group concluded that it was not possible to draw conclusions about the utility of EKG screening in methadone patients for the purpose of reducing mortality or morbidity related to QT prolongation. However, a lack of quality studies about this issue does not mean that we can ignore the issue. Rather, we can look at the options of experts in the field until we get better data from studies. In SAMHSA's Tip 63, their expert panel recommended the following: assess each patient's risk upon intake, ask new patients about personal history of prolonged QT syndrome, cardiac arrhythmias, prior myocardial infarction, unexplained syncopal events, palpitations, or unexplained seizures. Also ask them about family history of sudden cardiac death syndrome. Ask about medication the patient takes and note if any have the potential to prolong the QT interval. This list is relatively long, so OTP providers may want to use a smartphone app that lists drug interactions with methadone. Potential for QT prolongation will be listed among other types of interactions. Ask about or assess for electrolyte imbalances and make note of medications, such as diuretics, which can lower serum potassium and exacerbate QT prolongation. Also note that stimulant use, such as cocaine, methamphetamine, and amphetamine, can make QT prolongation worse. Also, do a risk stratification that includes performing an EKG at baseline if the patient is at additional risk for QT prolongation, with repeat EKG within 30 days. Repeat an EKG once a year. Recommend an EKG for patients at doses of 120 milligrams per day or more. When looking at the QT interval, you will see QT/QTC. You will want to pay attention to the QTC aspect of the EKG. This stands for QT corrected. The correction is a mathematical equation that addresses heart rate, as QT will vary depending on heart rate. Gender also affects how one interprets the QTC. A normal QTC for women is less than 450 and men less than 430. Borderline ranges for women are 451 to 470 and men 441 to 460. Don't start a patient on methadone with a QTC greater than these values. Be sure to discuss and document risks of treatment versus non-treatment with methadone, including looking at alternative medications. When in doubt, consult with a cardiologist or make certain the patient is being actively followed by a cardiologist. Ideally, this would be incorporated into the patient's treatment plan. Providers may want to consider buprenorphine as an option for patients at higher risk for QT prolongation, though some sources may say buprenorphine can also prolong the QT interval. Studies indicate it's much less likely to do so than methadone. Excellent guidance from SAMHSA is available to assist OTP providers in balancing the risks of treatment against the risks of delaying or refusing methadone's life-saving potential. If your facility has no way to get an EKG on an at-risk patient on the day of admission, perhaps you can start the patient on methadone and get an EKG later. We know from numerous studies that patients with opioid use disorder who enter treatment with methadone are between 3 to 8 times less likely to die from an overdose. And many of these studies were done before fentanyl became more prevalent. This suggests the risk of dying from opioid use disorder is most likely even higher now. In summary, while we want to take reasonable precautions in patients at higher risk for prolongation of the QT interval, we must weigh the risk against the known risk of delaying or denying treatment to patients with active opioid use disorder. We consider expert opinion in this matter until we get quality studies to answer our questions and do the best thing for the patient sitting in front of us. If you have further questions, please feel free to contact your state opioid treatment authority. Thank you for watching, and keep up the good work.